Aldosterone is often introduced as the hormone that helps the body retain salt and water, but that description barely scratches the surface of its importance in heart failure. Produced by the adrenal glands, aldosterone's primary job is to maintain blood volume and blood pressure. When blood flow to the kidneys falls, aldosterone signals specialised cells in the distal nephron to reclaim sodium from the urine. Water follows that sodium, expanding circulating blood volume. At the same time, aldosterone promotes the excretion of potassium and hydrogen ions, helping regulate electrolyte and acid-base balance. In a healthy person, this system is remarkably effective. If dehydration, blood loss, or low blood pressure threatens organ perfusion, aldosterone helps restore circulatory stability. The problem arises in heart failure. As the failing heart loses pumping efficiency, the kidneys perceive a reduction in effective blood flow. Although total body fluid may already be excessive, the kidneys interpret the situation as one of volume depletion. In response, aldosterone production remains persistently elevated. Initially, this compensatory response helps maintain blood pressure and organ perfusion. Over time, however, chronic aldosterone activation becomes maladaptive. The most obvious consequence is fluid retention. Sodium and water accumulate throughout the body, increasing blood volume and venous pressures. Patients develop peripheral edema, abdominal congestion, and pulmonary edema as fluid backs up into tissues and the lungs. The failing heart is forced to pump against an ever-growing volume burden. Yet aldosterone's role extends far beyond fluid retention. At the cellular level, aldosterone directly promotes inflammation, oxidative stress, endothelial dysfunction, and fibrosis. Within the myocardium, it stimulates cardiac fibroblasts to deposit excess collagen, transforming healthy, elastic heart muscle into a stiffer and less compliant structure. This process, known as cardiac remodeling, impairs both systolic and diastolic function and contributes to progressive heart failure. Aldosterone also promotes fibrosis within blood vessels, kidneys, and other organs. The result is widespread structural damage that further compromises cardiovascular function. Its effects on electrolytes are equally important. By increasing potassium excretion, excessive aldosterone can contribute to hypokalemia, which increases the risk of ventricular arrhythmias and sudden cardiac death. Alterations in magnesium handling may further destabilize cardiac electrical activity. By the time heart failure becomes established, aldosterone is no longer simply trying to preserve circulation. It has become a major driver of disease progression. It contributes to congestion, ventricular remodeling, fibrosis, arrhythmias, renal dysfunction, and worsening symptoms. This understanding transformed heart failure treatment. Clinical trials demonstrated that blocking aldosterone signaling with mineralocorticoid receptor antagonists such as spironolactone and eplerenone reduces mortality, decreases hospitalization rates, and slows disease progression. The benefits are greater than would be expected from diuresis alone, highlighting the importance of preventing aldosterone-driven fibrosis and remodeling. In many ways, aldosterone represents a central paradox of heart failure. It evolved to protect the circulation during times of physiologic stress, but when chronically activated, the same hormone that once preserved life becomes one of the most powerful forces driving the disease forward.